wanted to talk about a couple of different studies that some of your own children may have been a part of. So, standard treatment for Kawasaki disease. Everyone in this room knows what that is. You know, where we're at is with intravenous immunoglobulin, as well as with aspirin, Dr. Burns was just speaking about. A big part of the work that we're now doing in our lab is to try to understand how even IVIG works in this disease and to understand the immunology with the hope of either creating a better form of IVIG or also being able to develop newer therapies for children. And the reason that that really matters is that some of your own children, as you may know, may have gotten treated with IVIG, but then have had their fever come back. And that sets up kids for worse coronary artery disease. So this is a really critical question that we need to start looking at. And what I want to start with is just a definition to kind of bring home a topic that we discussed quite a bit, which is a clinical trial. And what is a clinical trial? There's several parts to it. It's usually about comparing the old and the new. So what I'll be talking to you about today is about a study that we conducted here that it compared IVIG to IVIG plus a new medication plus infliximab. And part of whenever you do a clinical trial, in order to keep us as unbiased as possible, is you really have to randomize kids. And what that means is it's kind of like the flip of a coin. So that when you come into the hospital and we say, we'd like you to be part of the study, your child's going to be randomized to receive one drug or the other. What we mean by that is that neither Dr. Burns nor I nor the nurse will know exactly what you get. The pharmacist has a fancy way of coding this so that they'll be able to separate the kids out, and the computer actually chooses what your child will receive. And so at the end of the study, what you've done is you've actually been able to put half the kids into getting IVIG alone and half the kids for this study into getting IVIG plus pharmaceuticals. But that keeps Dr. Burns and I blinded, as we say, so that all the things that we're looking out for whenever your child gets the disease, we're not biased by the fact that we know or didn't know that your child got infliximab. Okay, so randomization is really key. An essential part of clinical trials in order to be able to, at the very end, say that what you see is actually due to the drug that was given and not to something that we were really hoping would happen to your child. And again, we have the good fortune to work with a great biostatistician who's part of our clinical trials team, whose expertise is in clinical trials, to be able to do the math in order to figure out if the drug of interest is actually working. So here's the problem as I've laid it out. Here's a child that we had treated that you can see going on the y-axis up and down is the fever. And that red line there is what we consider fever. That's 38 degrees Celsius. Anything above that is a fever. And that child had gotten IVIG, and then the fever had gone down, as you can see initially, but then it went right back up. And this is what we call IVIG-resistance, which happens in about 10 to 15% of our kids. And the problem is that sets you up for worse heart disease. So a few years ago, probably actually more than 10 years ago, we became interested in the drug known as infliximab, and I'll describe that to you a little bit further in a minute. But you can see here that by giving this drug in this particular patient, that the fever went down nicely. And was that going to happen anyway, or was that due to the drug? And that's why you have to actually do a clinical trial to figure out if it was just going to happen by chance alone, or if it's actually due to the therapy that you're giving. So here's what we've been, what worries us and keeps us up at night. So when Dr. Burns and I, when our pager goes off in the middle of the night about a child that we've been caring for in the hospital, they got their first dose of IVIG, their fever and their rash subsided, we're very happy about that. We'll watch you in the hospital for at least another day, and we're watching for his fever. And then the pager goes off and we hear that that child had fever again. And the concern is that there's actually this overlap. This yellow section here in the middle is the overlap between resistance to therapy and having aneurysms. So coronary artery aneurysms alone, you can see there the percentage rate that happens in our children. That's the big red circle. And then the green circle there is the IVIG resistance. But what we really care about is this group here in the middle. And it's that overlap that actually leads to a 22% aneurysm rate in the middle. So your rate of having a coronary artery aneurysm is higher if you're treatment resistant. Okay, so that's what one of the big goals of our group is, to reduce the rate of treatment resistance for that particular reason. So that got us to thinking about how we're going to be able to actually achieve this. And it had us thinking about a particular molecule that I've already refer to the drug that actually blocks this, infliximab, and the molecule itself is called tumor necrosis factor alpha. I'll refer to it as TNF-alpha. And this is an inflammatory molecule. It kind of gets all your body revved up and going and sets off a whole cascade of things that are meant in some way by your body to be protected and fight infection, but can also cause a lot of damage, including leading to aneurysm formation. And so it's really like throwing fuel on the fire that happens with Kawasaki disease. And our goal is to be able to break that cycle. So here is infliximab, and what we have here are these little balls floating around. This is the TNF-alpha that gets produced by your body when you have inflammation. But the part that we were looking at was this drug, and it's infliximab. So it's an antibody that attaches to TNF-alpha and then takes it out of circulation. Okay, and that reduces inflammation in the body. This has been used in rheumatoid arthritis. It gets used in both adults and in children in several different kinds of inflammatory and immune diseases. And we thought, given that we had information that TNF-alpha is involved in KD, we thought that this would be a great drug to try. So that's how we designed a clinical trial. Now this all started years ago, before I joined the group, with some vision from Dr. Burns of using this drug, and she actually did the study to determine that this was safe in Kawasaki disease. So this drug gets given in many different ways. Most use is chronic. We are giving this as only a single use, and the safety has been beautiful and amazing. Now, many people have been so excited by the safety that they just have gone ahead and used the drug, but we really wanted to see if it worked, and we wanted to be able to document if it worked, and that's why we did this clinical trial. This trial was a combination, or it was really to look at if adding infliximab to IVIG as primary therapy makes a difference in kids by reducing treatment resistance. So we were very, very fortunate to receive funding from the FDA. It's the first FDA orphan drug grant that's been given to anyone at the university and at Rady Children's Hospital. We also partnered with Nationwide Children's in Columbus, Ohio, and we enrolled 196 patients over 4 years. Our goal was to decrease the rate of resistance to initial treatment of KD in the hopes of preventing aneurysms. And so here you see the study flow. Kids would come in, they get diagnosed with KD, and then they get randomized, again, that flip of the coin, to either get infliximab or to get placebo. So it's something that hangs by the bedside that looks like infliximab, but it's not. It's just some salt water, just like the IV fluid. But everybody in the trial, of course, got treated with IVIG because that's the standard of care. And then with intensifying this primary therapy, then we were looking for this whole concept of treatment resistance, and we were asking if there's a difference between the groups. And then, of course, we saw everybody back in clinic at 2 and 5 weeks to follow them up and look at heart ultrasounds. So with the primary outcome, this question of were we able to actually decrease the rate of IVIG or treatment resistance between the two groups, we actually saw no difference. And that is because, as you'll see here in the light blue, the rate actually of treatment resistance was exactly the same between both groups. Okay? So whenever you design a trial, the first thing you always have to do is say, I'm going to put this many kids into the trial to be able to answer this particular question. And our question was, do we reduce treatment resistance? And just looking at this, we would say, oh no, it failed. They didn't actually show anything. Well, the great thing about doing a clinical trial is that with all the data that you collect, you always set up other questions in addition to your primary question. And we've been very pleased to be able to get some very important information from this trial. And although we didn't meet our primary outcome, we actually have some very exciting news to share with you guys. So the first very exciting piece of this is that once again we've shown that this drug is safe. You said, well, you already told me that. I can tell you there's a lot of controversy around the globe about this particular drug. Even in Japan, for example, they refuse to treat any child with this medication below a year of age. We use it in several children that were below a year of age. It's our standard of care. If any of your kids, whatever their age group is now, our standard of care is to give this to a child with bad heart disease because we so fundamentally feel it's the right thing to do, and most importantly, it's safe. So it was tolerated very well in infants and in older children. But we also had several outcomes that were better in the infliximab group as compared to just the IVIG patients alone. The first part was that there were several markers of inflammation that were lower in the children that actually received infliximab. In addition, there was 1 day less of fever. Okay? And importantly, we looked at the heart ultrasounds, and we found that at least for the left anterior descending coronary artery, that there's actually a faster decrease in the size of that artery in the infliximab group as compared to those that just received IVIG alone. So we were very, very happy with all this, and in fact, it's actually made even the Lancet happy. I'm excited to share with you guys that just in the last couple of weeks, we received some great news that the Lancet have actually chosen to publish this, which is wonderful because if you look at the study, we didn't meet our primary outcome, but yet they were enthused enough with what we've been able to show with these other questions to be able to put it forward. So we're going to get a lot of really great press. We're going to be able to put this into a journal that a lot of people will read, and we're really hoping to change how children around the globe are treated with Kawasaki disease. So now the question is, what is the role of infliximab in Kawasaki disease? What have we learned? How will this change treatment? So as I mentioned again, I keep saying it, you know it's safe, okay? The data suggests also, as I mentioned, that we have a biological as well as a clinical effect. Now here at Rady Children's Hospital, if you come in and you're diagnosed with Kawasaki disease, I don't care how old you are, if your initial echo is abnormal, we're going to give you infliximab from the get-go, right after you get your IVIG. Because usually the kids will get their echoes after they've had their IVIG. And so this is our new standard of care that we're doing here, and that's all been informed by this clinical trial. Now, the other thing is that we still have a population of children that will fail initial therapy with IVIG. Just remember that most centers in the world will not do what we do. They will not give infliximab up front for abnormal coronaries. And so what we're hoping, and one of the points that we've made in this paper, is that there's probably a population of children where this drug still needs to be used, and that population is probably the ones that fail initial therapy. And so we answer a lot of questions from around the globe, from parents and from physicians, in particular from physicians that have very sick kids with KD, and we're always telling them, have you used infliximab? We have really great data. And now with it coming out of the Lancet, we'll be able to just point to that and direct them. So we're making some strong headway in altering how children with KD are actually fundamentally treated from the get-go, as well as for treatment resistance. And we've been very, very happy to be able to make these inroads. But it hasn't been, it hasn't been an easy thing. Every child from you that were enrolled in the study know that we sat down with you for at least 2 hours. And we just extend our gratitude to all of you that, you just met us. We just told you your kid had Kawasaki disease. And now we're asking you to be in a study when you're trying to figure out what this disease even is. So we are just really grateful to all of you for confiding in us and putting your trust in what we do with being able to generate such amazing information. So with that, our next big study, I'm going to move on to echoes the theme of tonight's gala, which is to save a child's heart. And I'm very excited to share with you the new study that we now are enrolling in. So I want to just for a moment share with you the current management of coronary artery involvement around the globe. That we follow your echocardiograms very closely to look for progression of disease. And then we hope that there's no clot, and we give the children anticoagulants to prevent clots and heart attacks from forming. But there really is no treatment that's given to stop aneurysm formation. Again, we've just started giving infliximab here to kids with coronary artery disease, but no one else does it that way. And really our hope is to be able to find a new therapy, an additional therapy that we can give kids to be able to stop aneurysm formation. And that's what we're going to talk about. So how can we do even better for treating kids with KD with a coronary artery damage? So as Dr. Burns alluded to, not to be ageist, but probably many of you, if you don't take this, your own parents have this in their medicine cabinet. Statins are so widely used by millions and millions of Americans. People joke about putting it in the water. So now I'm going to talk to you about using statins in Kawasaki disease. So the treatment paradigm here is that we are proposing to give atorvastatin, or Lipitor, for 6 weeks to help promote the healing of the coronary artery abnormalities in KD. You may say, Dr. Tremoulet, you're crazy. I don't want to lower my kids' cholesterol. Well, that's not what I'm trying to do whatsoever. That's exactly, of course, what this drug is marketed for, what the class of drugs is marketed for. But in fact, the reason why it's so commonly used is because there's data out there that the statins have anti-inflammatory effect, they have antioxidant effect, okay? And they also happen to promote vessel healing. Now wait a minute, that's exactly what we want to do in Kawasaki disease. So when a lot of the literature was coming out about statins, we thought, well, why aren't we using this and why aren't we trying it out in our Kawasaki patients? And as you can probably gather by now, the two of us are bold enough that if no one else has done it, that's okay with us. We're still going to move forward. But we're going to move forward very methodically, and we're going to prove first and foremost that it's safe. And that's exactly the trial we have going on right now, the safety trial. So the study design right now is if you come in and see us and your child is diagnosed with Kawasaki disease, if they have a normal echo, gratefully, they are ineligible. However, if they have dilated or aneurysmal coronary arteries, they will be eligible for the study. And so then children and parents are informed of the study. They, of course, get informed consent. We have a number of doses of the drug that we're giving. As we're walking through, we're actually trying to find the right dose to give kids. So it's called a dose escalation study, where you march through, and when one level is safe, you move to the next level. And then we're looking at just what I was mentioning right now. We're looking at drug safety. We're looking at how the body metabolizes the drugs, the pharmacokinetics. And then we're measuring things like the antioxidant reactions, the anti-inflammatory reactions of this drug. And so what I want to leave you with is where we're at right now. So far in this first dose level, we already enrolled 3 patients. And the way the study is set up is you can enroll between 3 to 6 patients. If you do really well and nobody has any problems with the drug, then you only have to enroll 3. And that's exactly what happened in our first lowest dose level there. And we're now at our second dose level. We've enrolled, in total, we've enrolled 4 kids. So we have 1 kid in the second dose level so far. And we haven't had any major serious adverse events. We're slowly marching through. This has gotten enough hype within the Kiwi world that Denver, Colorado, Children's Denver has joined us in the efforts. They're running a parallel study, and Dr. Linda and I are currently writing the grant to the NIH that we're going to be turning in this week for this exact study to put it forward as a 2-center study to be able to evaluate the safety and some activity of this particular drug with atorvastatin. So again, it takes a village to do this work. I'm always indebted and grateful to our patients and our families for believing in us. And I'm hoping that we may not be done by next symposium, but I'm hoping I'll be able to give you an update, certainly on NIH funding, but more importantly on how our kids that are in the trial are doing.